So the next couple of special tests are looking at stress testing and inter-joint manipulation or joint play, okay? So what we're gonna do with these is we're gonna identify where there's ligamentous structures essentially below the ankle. So we've already kind of crossed the ankle, we've covered those specific ligaments. Now we're gonna move to the tarsometatarsal joint, also known as the Lisfranc joint, and then down into the toes and look at the MTP joint, metatarsal phalangeal joint, okay? All right, so when we look at the metatarsal phalangeal joints, we wanna look at both the varus and the valgus stress test. That's gonna help us identify if there's any injury to the ligamentous structures that cross the joint itself. So in between for the great toe, you're looking at the proximal and the distal. For the 2 through 5, remember we have 3 phalanx, so we wanna do it at each of the joints, okay? So this is just like your varus and valgus stress test at the knee. You're gonna place one finger on the side that you are pushing your pressure through, and then you're gonna grab the end of the toe to create that stress at the interphalangeal joint. Okay, any pain with that? I'm looking for increased range of motion, then I'm gonna do the other side, okay? So this is essentially acting as my block, and then I'm gonna do that gapping motion, okay? At the smaller toes, again, I'm gonna isolate, feel that proximal phalanx, feel the intermediate phalanx, feel that proximal interphalangeal joint. I'm gonna provide my little stress there, my little stress. Ooh, you've got a little bit of movement there. Yeah, any pain with that?
A little bit.
A little bit, okay. Have you ever injured this toe before?
Not that I know of.
Okay. And then again, at the distal interphalangeal joint. When we're looking at the intermetatarsal joints, we're really assessing the deep vein, the deep transverse ligament, as well as the interosseous ligament, okay? So when we do assessment for our deep transverse ligament, we're typically gonna do a superior to inferior glide in between the metatarsals. For the interosseous ligament, we're looking at the glide in between the metatarsals. So I'll show you both of these in a moment, and then at the tarsometatarsal joints, okay? Later on, we'll get to the mid-tarsal joint, so our Lisfranc joint, and we're gonna do a little bit of dorsal and plantar guides, or glides, which I've already started to show you when we palpated the cuboid as well as the medial cuneiform. What you guys did at that point was a dorsal plantar glide over those joints. And then we will do some dorsal plantar glides at the cuneiforms, which we already talked about. All right, so when we are looking at the intermetatarsal glide, you're gonna have your patient in a short-seated or a long-seated position. It doesn't really matter. I'm gonna stabilize at the head of metatarsal 2. I'm grasping the head of metatarsal 1, and I'm doing that dorsal to plantar or inferior to superior glide between the heads. Okay, so I'm looking to see if that elicits pain. Sorry, I'm not trying to flip you off. Or if there's increased movement, okay? And I'm gonna do that in between each of the metatarsal heads. Things you probably shouldn't say on video. All right, so we'll go through each one of them. We're looking. So lots of movement there, which is pretty normal, no pain?
No pain.
Okay. So really you're looking in between for increased movement in between the heads, okay? We can also create space in between the intermetatarsal heads, so stabilize at the second metatarsal head, and then I can pull medially and laterally to see if there's any pain or increased movement there, okay? And that's demonstrated through this picture, okay? The next one that we are going to do is our tarsometatarsal joint play. And again, you guys have already done the medial cuneiform, but we'll do it again on this video. Okay, so we're gonna find the first ray or the first metatarsal. We're gonna palpate all the way along the shaft until we get to the tarsometatarsal joint. I'm gonna grab that medial cuneiform and I'm just gonna pull up and down. Okay, so dorsal to plantar. Any pain with that? And you can see Avery has a lot of flexibility in her in the joints of her foot. Do you ever have any pain?
Like in my feet.
Mm-hmm.
When I stand for too long.
Okay. And no injuries? So I'll show you the cuboid mobilization. So again, remember you're coming all the way down, the fifth metatarsal, come right off that edge, stabilize the base of the fifth metatarsal, grab the cuboid, and then do your dorsal plantar mobilization. Okay. You can do them throughout the midfoot, so that Lisfranc joint, that tarsometatarsal joint. It's a little bit harder to isolate, so we're right over the intermediate cuneiform. And again, remember the intermediate cuneiform is going to be in line with the second ray. You get a little bit of movement there, and then at the lateral cuneiform. Any pain there?
No pain.
Okay, good. All right, we already did the varus and valgus stress test of the toe. Okay, we've talked about the pulses, and you guys are very familiar with the capillary refill. Okay, we've talked a lot about foot structure, so we're going to kind of move through here. But again, here's a lovely picture of a nice flat foot. When this happens, our talus is going to tilt medially. Okay, so it's going to sit at a little bit of a tilt. And our navicular is going to displace inferiorly. So if you go back to the anatomy slides at the very beginning of this lecture, you'll see this picture of the navicular being what's called the cornerstone of the arch. Okay, so it provides that nice stability in the medial longitudinal arch. With patients who have pes planus, that navicular drops, and you can kind of see if you're picturing my hand as this would be the first ray, right? We've got our cuboid or our medial cuneiform here, and then our navicular. As the navicular drops, the arch flattens, okay? And so that's what you'll see is that navicular bone flattens or displaces inferiorly. Some of you guys may have seen your preceptors tape the navicular arch or the navicular bone with leukotape. So it's probably one of my preferred methods for treating patients with flat feet. So instead of just creating an arch on the bottom aspect of the foot, I'm actually lifting that navicular with leukotape and holding it into a more anatomically neutral position. Okay, we can do what is called the navicular drop test. So this is one that you will need your index card for again. Okay, so Avery, I'm actually gonna have you sit on the ground or sit on this stool. Why don't you sit, this way. So with your patient in a non-weight bearing position, you're gonna palpate that navicular tuberosity. And I'm going to mark it. Okay, I'm also going to mark it on my index card. And I'm going to put on that index card non-weight bearing, okay, to remind myself. I'm going to ask Avery to go ahead and stand up, putting all of your weight evenly distributed between your 2 feet. There you go. Beautiful. And you can see how much the arch dropped. Okay, so this is weight bearing, and this is left foot. Okay. All right, what we're gonna do is we're gonna look at the difference in centimeters between the height of her navicular tuberosity in non-weight bearing to weight bearing. Okay. The amount of difference indicates how much movement occurs in the navicular between weight bearing and non-weight bearing. And you can see with Avery's feet, in non-weight bearing, she's what we would consider a pretty neutral arch. In weight bearing, she drops into a little bit more pes planus. She's definitely not severe, but she definitely has less of an arch. So this just confirms our visual findings, okay? So what we then do with that, the difference in the measurement, so I'd measure this in centimeters. I'm gonna look at the difference, so you're gonna do some math. So subtract your weight bearing from your non-weight bearing. You're gonna find the difference. If you have a patient who has more than 2.3 centimeters difference between their non-weight bearing and their weight bearing height, they have what's considered a very flexible arch, okay? Between 1.8 and 2.3 is flexible, 0.6 and 1.8 is normal, okay? And we can measure Avery's if you want to see if she's normal or not, or I'll let you guys do it on your own. Okay, and then less than 0.6 is considered a rigid foot, and then less than 0 is considered a very rigid foot. Okay. Pes cavus, so high arches, we've already again measured each other with that, but again, just kind of connecting some pieces. Patients with higher arch or pes cavus tend to have decreased ground contact area. So as you look at their foot, you'll notice that they oftentimes will have lots of calluses on the lateral aspect of their foot, their heel, and then tons of calluses through the metatarsal, the first metatarsal head and the great toe. So fewer points of contact through the foot because the arch is so high. And it does oftentimes present in stress fractures. Your patients with pes cavus are more likely to develop stress fractures in the metatarsals and can benefit from having soft orthotics. Okay. We've already done the windlass test in class, but we'll do it one more time as it's associated with plantar fasciitis and looking at arch change. Okay, so the first thing that we're going to do, go ahead and hop up on the table, Avery. Again, we're gonna look to see, is there any arch in non-weight bearing? And the answer is yes. Avery has a lovely arch in non-weight bearing. We're gonna have her come off the table. And then gonna look at her arch in weight bearing. And again, we've already done this. So we see that there's a little bit of a decrease in height in weight bearing. Then I'm gonna give her my hand so she can stabilize herself. And we're gonna do your left foot, Avery, just so that the video can see a little bit better. And you're gonna go up on your toes as high as you can. Sorry, just your left foot, not your right. Beautiful. And hopefully you guys can appreciate and see on your own. She has a greater amount of arch in her heel raise compared to weight bearing. Any pain with this? Okay, you can lower yourself. So you guys might have seen, but I was holding Avery's hand to give her a little bit of stability. Your patient can also do this next to a table. So hold the table and then just go up into a heel raise. Okay, obviously you can't see my arches in my shoes, but you can see Avery's feet as she does this, holding the table. You don't need a high-low table. You can use a couch, you can use a dining room table, you can use whatever your patient can stabilize on, okay? Pain with this or an absence of an arch being created, pain is gonna indicate plantar fasciitis, potential plantar fasciitis. Lack of an arch being created can indicate a medial longitudinal arch rupture or a plantar fascial rupture,